Hello, Professor. Welcome back.
Oh, good to be back with you, Brent.
So today we are going to talk a little bit about testing. We touched on SARS-CoV-2 testing last time we spoke, but could you maybe give the audience a bit of a sense? They've probably heard about some of the confusion going on, but about the challenges health systems are facing with diagnostics right now.
Well, specifically with SARS-CoV-2, there's been obviously a lot of anxiety about spreading the virus around the hospital. So normally, what we would do, the ICUs are usually located quite a ways from where the laboratories are. Of course, labs, the prototype is always in the basement, right? So what we do is we hook up with pneumatic tube systems. And you can imagine what might happen if you had a breach in a pneumatic tube system, which can send a tube perhaps 2 or 3 blocks in just less than a minute. So it's going quite quickly. If that were to breach and the air to go through, it could contaminate large swaths of the hospital. So for many of these, and at our institution in particular, if a COVID positive patient has specimens collected for lab studies, they have to be hand delivered to the laboratory. So that usually is, in our situation, about 2 blocks away as the courier walks. So it takes a long time. It requires human beings to do it. These patients are very lab intensive. They get a lot of lab testing done. So it's many samples brought to the lab every day. And this is what makes point of care testing so popular, or such a good option with these patients, because they are devices that can be located right up in the patient area. And so they would be, if there's a COVID ward, they would be contaminated certainly, but they would be able to be used on many of the patients right in that area, and that mitigates having to do all this couriering down to the laboratory. So that's one big challenge, and how that many institutions are meeting it is by implementing more point of care in the COVID in the areas that house COVID patients.
Now, you mentioned point of care diagnostics. What is meant, we hear the term rapid test with COVID-19 a lot. What's meant by rapid? Is that actually defined in a stringent way?
So not particularly. It's so rapid may be that it has a 24-hour turnaround time. That would be some rapid microbiology test, for example, or it could be a test like a CBC that can be done in just a few minutes. So we think about it as vein to brain. The patient, when you think of the test order, the time from when the patient has the specimen collected to when it's in the caregiver's or the practitioner's brain. So by rapid testing with COVID, if you're talking about measuring the virus itself or measuring the virus as an antigen, then those tests, they can be as rapid as, say, 15 or 20 minutes. But those are point of care tests, and you do, in general, you do sacrifice some diagnostic performance. For example, some have been reported to have false negatives. In other words, it's really a positive test, but it's reported by the device as being negative. So this is why generally these come down to the lab, and rapid would be about 2 hours or so, 1 to 2 hours after it arrives.
You mentioned the problem of false negatives. Now, I don't know if false positives is the right term, but there have been stories about, I suppose, debate over what the right sensitivity to pick up actually infectious virus with a PCR would be.
Right.
Can you speak to that at all? I think that's a very difficult thing to parse, even for people in the field.
Right. So I think what we have to think about this like is like detection. So if baseline is here, like basically zero, there has to be some level above which there's noise. Okay, there's noise just from the device. So you want to have your cutoff for a positive result just above that noise. Well, sometimes devices don't have the sensitivity to really get down so close to what might be that difference between normal and abnormal. And this is what PCR really brings, because what PCR allows you to do is magnify that signal by powers of 10, so by orders of magnitude, so that you can get a signal that's way above that threshold, or at least up to that threshold. And that takes time. So that's one of the limitations of perhaps some of the point of care devices, because it does take several cycles of the PCR in order to get the signal up where it can really be detected reliably from what might be baseline and a false positive result. So that trade-off between being above a cutoff and being positive, or below the cutoff and being negative, is what we're talking about, and try to get good discrimination between being above that cutoff or below it.
How about as far as testing strategies and tactics? I've heard the term decentralized testing. Can you tell me about that?
Yeah, so decentralized testing, rather than having like I was mentioning before, one mega lab in the basement which is hooked up by tubes, that you could have satellite areas near to the areas of where patients are housed. For example, in the Ebola crisis, which was a few years ago now, and really the outcomes were even far worse than what we see with COVID-19, but still, so they had satellite labs that were near the treatment area, because there was quite sophisticated testing that needed to be done there, but you didn't want these dangerous samples carried throughout the hospital and so on. So those are there were areas of expertise, or centers of expertise, for example, Emory in Atlanta, CDC in Atlanta, other areas that really had it worked out where the lab would be decentralized. So there'd be a small lab, a satellite lab, right near the area where the patients are housed.
What are some of the advantages of this? I mean, is it a speed thing? Is it a safety thing? All the above?
I think it would be all of the above. The closer the lab is to the clinical area, the better we can really serve the clinicians' needs. Be able to get the results to them quickly. Be able to see when they're preparing to send the sample, so get everything staged, and it becomes much more of a sort of really part of the clinical team, rather than a lab that's in a distant area that is where behind the curtain, just like in The Wizard of Oz, I guess, where the things behind that curtain you don't need to worry about. So yeah, it really allows really to be a team that takes care of these very infectious or very ill patients.
Well, I mean, to that point, actually, the need for a team and the sort of Oz behind the curtain, what are some of the challenges that the people in the labs are facing right now? I mean, there's such a demand for testing. What is that environment like in terms of day-to-day responsibilities changing from before the pandemic and things like that for the people working on it?
It used to be, well, I mean, I can say that since the sort of the COVID era, and I'll call that maybe late February this past year to March, it has been pipeline. So we never, things were back ordered. It was difficult to get reagents. Once in a while, there would be a problem, but there was just such a rush for most of the reagents that were used, that were specific to the SARS-CoV-2 detection and measurement, that most of the medical centers had to get, we couldn't go with just one vendor. We had to have maybe 3 or 4 vendors for most of these, for the PCRs, for example, because in 1 week, one of the vendors might run out of reagent nationally. And what are you going to do? You're going to stop measuring, stop assessing patients for whether they have the SARS virus or not? No. So it really put us in a position where we had to get a number of different technologies in that so we could assure that we'd be able to deliver the services to our patients. And boy, that happened with many of the SARS-related reagents, both for antibody detection, for looking for folks that may have been, or healthcare workers that may have been exposed, as well as to the PCR testing that was for acute detection of COVID-19.